Thank you. Welcome to the Traumatic Brain Injury, Falls and Aging webinar hosted by the Ontario Neurotrauma Foundation in partnership with the Public Health Agency of Canada. My name is Hélène Gagné, and I'm the Program Director for the Injury Prevention Program at the Ontario Neurotrauma Foundation, which we call ONF. ONF is a nonprofit organization funded by the Ontario government that works to prevent neurotrauma and ensure Ontarians with spinal cord and brain injuries lead full, productive lives. ONF is the leader in moving research to evidence-informed health practices that improve the quality of life and health outcomes. Through collaborations and partnerships, ONF connects healthcare practitioners, researchers, policymakers, and stakeholders to the information they need to make positive changes in health practices, outcomes, and policies, particularly as it relates to fall prevention initiatives. ONF is currently sponsoring and leading the Canada-wide Fall Prevention Community of Practice using the bilingual communication platform Loop, and is providing support to the Fall Prevention Month initiative led by 13 provincial and national partners. We have a vested interest in supporting research and evidence-informed interventions that prevent falls in older adults, which can lead to traumatic brain injuries. We are pleased to be offering this webinar with simultaneous translation to French, graciously provided by the Public Health Agency of Canada. Before we begin with the webinar, I'm going to give you a quick rundown on the Level 3 web meeting system. The webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link for the web platform were sent to you by email after you registered for the webinar with Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box located on the left-hand side of your screen. Alternatively, you can send an email to lindsay@onf.org. We will work with you to resolve technical issues as soon as possible. This webinar contains an opportunity for discussion during the question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, we will read the questions aloud to the presenters. All questions should come in through the chat box today. There will be no questions over the phone. Before we begin the webinar, I would like to introduce Marzia Tafagod, the manager of the Seniors Health Promotion Unit at the Public Health Agency of Canada, who will say a few words.
Thank you very much, Hélène. I would like to thank my colleagues at the ONF for their fabulous work in the area of brain injury and for co-hosting this webinar with us today. As Hélène indicated, my name is Marzia Tafagod, and I'm the manager of the Seniors Health Promotion Unit at the Public Health Agency of Canada. The agency recognizes the importance of falls and the effect they have on the lives of older Canadians and their families. We strive to increase the awareness of the risk factors and available fall prevention strategies at the federal level to help mitigate the impacts of fall-related injury. This is why we were keen to co-host this webinar today on traumatic brain injury, falls, and aging. It gives me great pleasure to introduce the speakers for today, Natasha Kern and Dr. John Puxley. Natasha is a senior advisor for the same unit I am with, and she will present today on the surveillance data and the trends of TBIs and falls in older adults. Following her will be Dr. Puxley, an associate professor and chair of the Division of Geriatric Medicine at Queen's University, the chair of the Southeastern Ontario Regional Geriatric Program, director of the Centre for Studies in Aging and Health, and chair of the Seniors Health Knowledge Network. Dr. Puxley is also the lead physician of the Southeast Advanced Care Planning and Healthcare Consent Working Group. And with no further ado, I turn it over to you, Natasha. Thank you.
Thank you, Marzia. So I'd also like to reiterate the thanks for joining the webinar today on traumatic brain injuries, falls in older adults. As Marzia introduced me, my name is Natasha Kern, and I'm presenting this information on behalf of the Public Health Agency of Canada. So I work with the Seniors Health Promotion Unit, although the information I'm presenting today has been analyzed and collated by our surveillance division. As this is a fairly new area of exploration for surveillance data at the agency, the information I'm able to provide is preliminary, but it serves to highlight the need to ask a lot more questions. So I'm going to set the context quickly about what I will touch on today before we turn to Dr. Puxty's presentation later. So I will be looking at falls in Canada in terms of what the big picture is, then getting into some of the surveillance data, specifically on traumatic brain injuries in seniors and the TBIs that occur as a result of falls. Before we start, I just want to briefly touch on the fact that falls are a very serious public health concern, but they're one that can be addressed. In 2014, we had released the Seniors Falls in Canada second report, which is available online, and it highlighted the grave situation associated with falls in older adults. The data used for both the report and today's presentation have all been taken from Statistics Canada's Vital Stats and the Canadian Community Health Survey, as well as some of PHAC's data on the hospital morbidity database. So if we look at falls in a Canadian context, for those who don't work in the area, I just want to give a quick recap on the importance of falls as a public health concern. And we are actually very often asked why the Seniors Health Promotion Team focuses so much on fall prevention as a public health issue. And I think this particular infographic that was produced to support the more fulsome report I'd mentioned earlier serves to highlight some very key and pertinent facts about older adult falls in Canada. And as you can see, the numbers are quite staggering. So 20 to 30% of older adults fall each year. Falls are the leading cause of injury-related hospitalizations for older adults. Over 1/3 of adults have to move into long-term care after being hospitalized for a fall. 20% of adults die within 1 year of a hip fracture. And in 2011, there were over 1 million emergency room visits due to fall injuries across Canada. Now that last stat is for all ages, but it's a shocking number when you think about it. And the cost to all of us is even higher than what's on the infographic that we have posted online. Parachute Canada now estimates the cost of falls in older adults to be $3.4 billion per year. So we know that falls are well known to be a linchpin of multiple issues affecting the lives of older adults, such as sensory impairment, chronic disease, poor mental health, social isolation, less than ideal housing, incontinence, dementias, the list goes on. So what's interesting is that the common factor to all of these is that they all present a very high risk for falls. But where do falls and traumatic brain injuries intersect? Concussion awareness is a relatively new field. There's been a lot of attention paid recently, particularly in Canada and the US, to concussions and other head injuries in youth and sports. But analyzing the concussion data more closely, the hypothesis put forward in the Falls report that we mentioned from 2014 about the incidence of traumatic brain injury, or TBI, I'm going to start referring to it as TBI for time issues, related to falls and seems to bear weight. So essentially it shows that not only children and youth experience high rates of head injury, but a disproportionate number of older adults do as well. TBI are most common when an adult falls forward, for example, tripping up a set of stairs or falling face down on a wet bathroom floor. Now, this leads to the question of what exactly is a TBI, and Dr. Puxty is going to speak to these definitions in detail. He is much more expert in this area than I am, but I want to say for the purposes of the surveillance data, it's defined as an intracranial injury, so ICD-10 diagnosis codes, as coded by PHAC in the hospital morbidity database. So interpreting the data and outcomes related to a TBI for the purpose of the information that's being provided today was very specific to that ICD code, but it doesn't communicate to us necessarily how severe the TBI is. So accurate reporting and understanding of the potential progression of a TBI is very important because severity does have a huge impact on the outcome. And I look forward to Dr. Puxty's presentation on that part. So why are we worried about TBIs in older adults? Well, they're an important cause of both morbidity and mortality, especially in children and youth and the elderly. And they can lead to long-term disability related to the development of post-injury symptoms or even possibly death. So looking at the analysis, as I said, these cases were extracted from the Hospital Morbidity Database through CIHI, the Canadian Institute for Health Information. Incidents were included if the most responsible diagnosis was an intracranial injury, ICD-10 as I said, and the external cause of injury was a fall, and the patient was aged 60 years or older. The results were both surprising and disturbing. Older adults experienced an approximate 15% increase in injury-related hospitalizations between 2004 and 2010, with the majority of this increase related to falls. In 2010, there were a total of basically just under 18,000 hospitalizations related to traumatic brain injuries across Canada for all ages, but 50% of these were experienced by adults aged 60 and over. Falls accounted for 78% of hospitalizations for traumatic brain injuries in adults over the age of 60, followed by transport collisions at 9% and assaults at 2%, and the rest due to other mechanisms. So this incredible discrepancy in what's causing the TBIs and hospitalization is quite noticeable. TBI-related hospitalization as a result of sport also accounted for 2% of this age group. What's interesting is that we have to remember that the surveillance team went in looking for sport and youth-related concussion data, and this is what actually came out of it. So it's actually quite a surprise, but a very disturbing one, as I said. So basically what we're noticing is that there's a trend of TBI in older adults that has not been particularly well articulated. So what are causing these TBI hospitalizations from what we can tell at our first sort of cuts of the data? What we're looking at, as I said, is 78% of these are due to falls, 9% motor vehicle, and 1 to 2% on assaults. But what's not clear from this data is whether the person presented themselves to the ER immediately at the time of injury or later, once symptoms had either manifested or they hadn't lessened. So did they go in right away, or is this a couple of days later and it's just not going away? And at that point, that can have a huge impact for recovery implications. So from some preliminary literature research, there may in fact be under or late reporting of TBI by the individual, as it may first be perceived as a minor ache or pain, and I'm saying this with little quotation marks, common to old age, simply because any ache or pain should really be investigated and not minimized as a part of the normal process of aging. So flipping to the next slide, which shows us where the age spread is, there's a definite trend within the older age range. So you're at increased risk of being hospitalized with a TBI as you age, and it peaks in the 15-year period between 75 and 90. International literature suggests that the increase in TBI for this age group may have resulted from what are risky behaviors for an older adult, such as climbing ladders. But here's where we have to be cautious about how we say it, as the action the person is undertaking may well have been within their capability for most of their adult lives. But changing resiliency and ability to recover from the injury will make the impact that much more profound. And there's a fine line that we must all walk to respect an adult's right to make the decisions and accept risk, and making sure those decisions are informed with the best information possible. Which leads us to sort of our conclusions, or where we're at this point. It's not so much conclusion as it is a where we are at right now. So we know that traumatic brain injury resulting from a fall is a significant issue for adults over the age of 60. We know we need to look at this in more detail. The increased hospitalization rate related to falls among older adults, in addition to the increased number of older adults in the Canadian population, will only escalate this issue. But the data analysis so far has only given rise to more questions than answers on our part, leaving lots to explore. For example, whether the TBI occurred in long-term care or in community-dwelling adults, and this will have an impact on home care, which is an issue of great concern right now as more adults wish to age in place. The location where the TBI occurred, on stairs, bathrooms, inside or outside, this information isn't readily available at this time. What activity resulted in the TBI? This needs a little bit more detail in the Canadian context, because as I say, we were speaking to international literature before. whether the TBI resulted in long-term care admission, or if long-term care admissions are resulting from other types of falls, whether the data is different based on gender. In general, this type of question has been available for falls in the PHAC Falls report, but more specific attention needs to be paid to the outcomes resulting from a TBI associated with a fall. And as I said, we have to consider falling and TBI as part of the continuum of care that will allow older adults to age in place. But this is a starting point that we recognize it's a very significant public health issue, particularly in light of our aging population demographic. Thank you. I believe we'll be saving questions for last, which suits the flow of our talk well, as Dr. Puxi will provide more context to the issue of TBI in older adults specifically.
Okay, I guess that's my cue to take over. Thank you, Helen, for those earlier very kind comments. I'm going to be speaking from the perspective of a geriatrician, though, not necessarily my research hat. As a geriatrician who regularly attends on a consult service to an acute care hospital and also a geriatric rehab unit, and also as a physician who works in a memory disorder clinic, where I often see individuals where the story of traumatic brain injury, or TBI, may be remote to their initial presentation, but it has a direct link to the consequence of their cognitive impairment. So as mentioned, we're addressing today the issue of traumatic brain injury in older adults. Now, the majority of us, we celebrate the fact that as we age well. But there's a tendency towards aging for reduced physiological reserves and therefore reduced capacity to respond to stress. So in the context of traumatic brain injury in older adults, there may be more consequences of that injury because of inability of the person to adjust. Also, we often see that many older adults, extremely old, individuals over 85, often have multiple comorbidities. So with these multiple chronic diseases, the traumatic brain injury is superimposed on a complex health and medical situation. So it's not uncommonly that the impact of even moderate traumatic brain injury may have a greater consequence in older adults. So I wanted to just briefly review some of the terminology we use in relation to traumatic brain injuries. We tend to talk about two main groups, primary and secondary. Primary injuries would be injuries that occur at the time of the immediate trauma. Secondary tend to be displaced chronologically, typically over hours or days, and may in fact relate to other complications such as hypoxia, cerebral edema, hemorrhage, or raised intracranial pressure that weren't directly a result of the primary head injury. In terms of primary traumatic brain injury, we tend to talk about two main groups, either closed or open. In terms of the closed injuries, we tend to be dealing with what may be the direct impact of a blunt force impact, or we may be dealing with an effect of either rotation or acceleration or deacceleration of the brain and impacting on the dura mater or the skull. The open brain injuries can usually be described, also be distinguished in terms of those which are associated with fracture of the skull, where the skull itself fragments may cause injury, or those in which the offending article itself penetrates the brain and causes injury. On this slide, I've just included some of the main definitions for the types of injuries we see. As noted, concussion tends to be the more common injury. It's often said to be a milder injury. There is always an associated impairment of cerebral function, usually in terms of some period of unconsciousness. More significant may be if there is actually a bruising or contusion of the brain. We often see two different types of contusions. There may be those which are at the direct impact site, and they tend to be impacts with things such as small, hard objects, where there's an immediate injury to the brain underlying the site of injury. Contrarily, we can also see impacts from a larger object where the force tends to be dissipated over, and there's less direct injury at the site of injury, but actually the injury occurs at the contralateral side as the brain doesn't move as fast as the skull, and in effect the contralateral skull contact causes the injury to that part of the brain. There's an important term which needs to be understood, which is the one we term diffuse axonal injury. And this happens when the brain is being slammed back and forth inside the skull. It may cause both compression and stretch of parts of the brain, but particularly the neurons. If the neurons, the axons of neurons, are compressed and stretched, they may be torn. And we term that axonal shearing. When that happens, the neurons will die. And when we see diffuse axonal injury, it's nearly always associated with severe traumatic brain injury and often results in a vegetative state. It may be helpful just to clarify a little bit how we distinguish between severities of traumatic brain injury. Two of the main classifications are the duration of unconsciousness. So, for example, unconsciousness of less than 30 minutes is usually deemed to be a mild traumatic brain injury and probably associated with what we would term concussion, whereas a period of unconsciousness of more than 6 hours is often termed severe and often associated with significant neurological consequences. Some of you may have heard of the Glasgow Coma Scale, which is a 15-point scale, which really based on a scoring of the individual's motor response, verbal response, and eye opening. And basically, the higher the score, the less severe the damage has been. So the individuals with a Glasgow Coma Scale of 3 to 8 are often quite severely impacted upon by the traumatic brain injury, and as we'll talk about later, quite often older adults do worse with moderate and severe TBI than younger individuals. So, unfortunately, what I'm trying to reference in this slide is that there tends to be some ageism in how we respond to older adults with traumatic brain injury. Although these individuals are more likely to have complicated courses, more likely to have existing comorbidities like problems of COPD or chronic obstructive airways disease, these individuals are often less likely to be transferred to intensive care unit, often are less likely to be treated by staff with the appropriate seniority or skill sets, and are more likely to not be transferred to non-trauma specialty hospitals. So there's a tendency for older adults not only to have a more severe consequence from the traumatic brain injury, but they may not actually receive the same level of support that may be given to a younger group. There is a worsening of prognosis in terms of traumatic brain injury. We know that mortality rates are higher, particularly in those with moderate to severe traumatic brain injuries. The prognosis also tends to be worse than younger age groups, particularly in the middle to older, particularly in relation to those with moderate to severe injury. We tend to find that actually in studies that have been done, that older adults with mild traumatic brain injury, so perhaps concussion, do at least as well as younger individuals with the same degree of traumatic brain injury. There's also some suggestion that the very old, individuals 80 and plus, do less well than individuals who would be termed young elderly, who are in the 60 perhaps to 75 age group. And a number of researchers have looked at this, trying to tease out why, and it probably relates to multiple factors, probably the comorbidities in the very old, possibly also the fact that the very old are unfortunately less likely to access some of the resources that might mitigate the effect of the traumatic brain injury. There have been several studies which have looked at the value of rehab in traumatic brain injury and aging. There does seem to be some difference in recovery rates in terms of rehabilitation in the young and old in terms of traumatic brain injury, if cases are matched in terms of severity of the traumatic brain injury. But there does seem evidence that at least in the mild to moderate traumatic brain injury, older adults do benefit from rehabilitation, although the speed at which they rehabilitate may be slower than that of younger individuals. There's also some evidence that the recovery from traumatic brain injury probably plateaus in older adults at 1 year, whereas there's evidence that in younger age groups, recovery may continue to happen for 3 to 5 years after the original injury. In older adults who've survived traumatic brain injury and who are followed up perhaps 3 to 5 years later, there is an increased incidence, unfortunately, of some morbidities. For example, older adults are more likely to see problems in terms of seizures, Parkinson's disease, or even cognitive impairment associated with dementia. Some evidence also that they may be more prone, because of other injuries to other parts of the bodies, to problems in terms of arthritis and joint-related disorders. There tends to be a greater functional impact from the traumatic brain injury, so the individual may become more deconditioned over time, and therefore their functional recovery, secondary functional loss, may be greater. I'd like to talk a little bit about cognition, because some of the statistics that were presented are significantly concerning. But we also need to realize it's not just individuals now who have traumatic brain injury that we're seeing clinically. There is this problem that individuals with traumatic brain injury over time seem to have an accumulation of cognitive impairment. We see in the short term, not uncommonly with many individuals, even with mild TBI, in the first three months, that there's some cognitive changes, but many of these individuals will recover, and often at a year are functioning quite well within the community. The challenge is, if we follow these individuals over time, there's clear evidence that they may be more at risk of developing long-term cognitive deficits and dementia. We often, within a memory disorder clinic, inquire about a history of remote head injury, and we know that this is one of the significant risk factors for Alzheimer's dementia. Studies have looked at the brains of individuals who've had traumatic brain injury, and there's some evidence that these individuals are more prone to develop neurofibrillary tangles, which is one of the hallmarks of Alzheimer's dementia. There's also some evidence that individuals who have a probable genetic predisposition to Alzheimer's, who have traumatic brain injury, are more likely to go on to further cognitive loss and dementia. So, from a public health perspective, we need not just to worry about the immediate consequence of the traumatic brain injury, but be aware that down the road, in 5, 10, 15, 20 years, these individuals may develop premature cognitive impairment and dementia. But if we turn to a little bit more positive view of traumatic brain injury and aging, it's interesting that if you follow over time, typically individuals over several years, older individuals who suffer traumatic brain injury often report a higher quality of life than younger individuals. They often report greater life satisfaction. It's particularly true if there's a strong supportive family, and particularly if they have an engaged spouse. There have been a variety of explanations offered to try and explain why older adults with TBI may report a better quality of life, and it may be that these individuals, older adults, have a reduced expectation. Perhaps they were already retired and used to a more sedentary life, so some of the deficits, some of the impacts of the TBI may have less consequence on their pre-morbid lifestyle than in a younger individual. So, in summing up, traumatic brain injury is clearly an important topic. We have strong data to suggest this is an increasing problem in older adults. It's a consequence that may in fact be moved forward chronologically 5, 10, 15 years in the future in terms of impacting on cognition and function. And falls are a key factor. And if we can't prevent the fall, at least as you can see with this gentleman in the slide, we can try and prevent the injury. And I've seen this type of head device used in individuals who continue to fall, and it has been successful in at least preventing them having a traumatic brain injury. There are a few resources that we might flag that you could perhaps access. Recently, there's been some new brain injury guidelines which were posted on the website as noted over here. So I guess we'll now move to any questions and discussion.
Thank you, Dr. Puxi. It's Natasha again, and I'm going to facilitate the Q's and A's. You've provided a number of very interesting points for consideration, and in particular, I was very intrigued by underscoring the need to consider severity in terms of what the outcomes are going to be, both in terms of immediate treatment and rehab long-term, as well as the ageism in addressing TBI in older adults, both in the ER room and elsewhere, frankly. And I'm wondering a little bit more about the accumulation of long-term impacts resulting from the TBI and what impact this might have on an even younger generation, so we can look at a lifespan approach to concussion awareness and treatment. Because from the data that you're presenting to us, I'm wondering if there's maybe linkages long-term that we could help people better prepare for. And it was also interesting the protective factors that you touched on that help offset some of the outcomes of TBIs. I have to say all of it can be quite overwhelming, and we don't want to leave webinar participants with a feeling that there's no interventions that can be effective to prevent the falls that cause these TBIs that are so damaging. So quickly, before we turn to the Q&As, I just wanted to draw everyone's attention to the Loop platform that John actually, sorry, Dr. Puxi, you had it up on a slide. Thank you. Yes, the useful resources. It's a website supported by ONF and the Ontario Fall Prevention Collaborative. It's a fantastic resource for materials and information sharing on fall prevention approaches that's available year-round. And there's also the toolkit that Alain had alluded to earlier that we had been working together as a collaborative for the November Fall Prevention Month in 2016. And so that link at the top will bring you to the toolkit, and it's available also year-round, although the activities that are highlighted we're obviously focused on in November. So if as a practitioner you're looking for some suggestions and interventions, please do access these fantastic sites. Turning to questions, actually, Dr. Puxi, I'm just wondering if you perhaps have, I'm going to put you on the spot for a second, and maybe if you have an example that you could share with us from your experience that before we turn to the Q&As from the group.
Sure. So coming back to the comment you made about the lifetime consequence of traumatic brain injury. I've seen a number of people recently within the memory disorder clinic where there's a positive history of an injury, possibly in their 30s, 40s, or early 50s, and it's 20 years later they're presenting with some cognitive deficits. One particular case I can think of, the individual, it wasn't a fall, it was a road traffic injury where she sustained significant injury to the left side of her head, and therefore some associated what we term parietal lobe injury. At the time, she was in coma for several days, but gradually over a period of weeks and months, she made what seemed to be a total recovery and led a very normal life and full life. Although it was noted post-injury, she had some mild problems with occasional word finding. And then in the last 18 months, when she's now in her 70s, she's now presenting with more notable problems with word finding, some problems with wayfinding, difficulty particularly when driving, and some mild memory deficits. The interesting point was that if we only looked at her cognitive assessment, there was a dominance of parietal lobe findings, but very relatively small findings for other parts of the brain. So my working idea is that this lady probably does have mild, very mild, Alzheimer-type dementia, but it's now superimposed on previous parietal lobe injury that she had been able to compensate for some 30 years in the community. And now, because she has this reduced reserve capacity, as she's now developing early Alzheimer's dementia, she's showing much more dominant language and visual spatial problems than we would have expected. So understanding the traumatic brain injury helps me understand and interpret for the patient and family. So in her particular case, the positive aspect is that we were able to explain some of the challenges in certain situations and also suggest that in her case, in many areas of her brain, there was relatively good, well-preserved function. So there were strategies they could use to compensate for some of these challenges they were now seeing in her day-to-day life.
Thank you. That's an excellent example. It gives lots more food for thought, actually. And I'm sure everyone appreciates having a real-life example to be able to put some of this data and information to. And it gives me reassurance, as you say, that there's some steps that we can take and action to prevent the falls and increase some resiliency to recover from injury when it does happen. I'd like to turn now to the Q&A. We have a number of questions, if that's okay with all the presenters. So starting with, we will go up to Trudy asks. She's noting that in the data on page 9 from my presentation, that the data should, here, let me pull that up for everybody, that she's asking to basically have, for all of these stats, a representative number of Canadian population, because essentially saying that she should show the total number of population below the bar, so it's clear that the percent hospitalized, that the low numbers in the 90s is probably the result of low population over 90. So it is a good point to make sure to take into consideration the fact that you're going to have a different population, and that may actually, in fact, skew the data. To Trudy's point, the fact that there are more people in the younger age categories may actually mean that they actually have a less representative proportion than, for example, if we have fewer older adults, but they're falling and having a TBI at a higher rate. So that's actually a very good point of something for us to take into consideration when slicing the data the next time around. We don't have that information currently available for this presentation, but thank you for bringing that up, Trudy, because I think it's quite valid and could show an entirely different concern that we need to look at. Then Loretta's asking if there's data differentiating falls leading to TBI in long-term care versus the community. And do we know the causes of falls that are more likely to lead to TBI? So from the surveillance data that we had, those were actually two questions that I had noted are still outstanding for us to explore, because we weren't able to access where the place of the fall or what was occurring at the time of the fall that caused TBI. But I'd actually like to turn it to Dr. Puxty, and you can say no, Dr. Puxty, but if you've had any personal experience or knowledge of what tends to be the cause of TBIs in the older adults that you see.
Well, probably, okay. So for the people who referred, the problem is there's undoubtedly an under-referral of many individuals. Many of the individuals who I'm asked to see who've had traumatic brain injury are in the moderate to severe category. They're often individuals who currently the existing service are not seeing progress and not able to be discharged. More commonly than actually, they're probably about 50% are related to road traffic accidents or similar, and about 50% related to the falls that individuals have had. I see a lot of people where I find out there's a remote history of TBI within the last several months. And on CT scan, I see evidence of a hematoma or evidence of a contusion who were not referred at the time of injury. And many of those are falls related. So I guess the key message is there's probably an underappreciation and under-referral. I think if the individual doesn't have an immediate neurological consequence from the injury and is capable of being discharged, I think many are, even though there may be consequences in the weeks to months as still of that TBI, that they would have benefited from some form of rehab. And unfortunately, I think a number get admitted to long-term care without proper rehabilitation.
Thank you. And actually that's reinforced by the literature scan that we've been doing, which was saying that people are not going in when it happens at the time. It's sort of brushed off or as you say, discharged because there's no exact symptoms. And actually, I'm going to skip ahead to a question because that ties into Cecilia's question to us, and I'll come back to Carol in just a second. But Cecilia asked, if a person falls and within a few hours this CAT scan's done and there's negative results, should we take it that no delayed effects can be expected? Or how long should we be vigilant in our monitoring? For example, is it between 24 to 72 hours? Can you give some feedback on that?
Okay, so if there is head injury and any altered level of consciousness, I think that warrants monitoring even if the CAT scan is negative, because the CAT scan won't necessarily show changes in a concussion. But we do know that a concussion can have significant consequence over days or weeks in terms of that person's performance and function. And not the least of the fact that because of their associated altered level of consciousness, because of the concussion, they may be at risk of more falls. And that's certainly a history I've seen several times of individuals who've had a head injury, who have a concussion state, who have a normal CAT scan, who are discharged, and who are readmitted within a matter of days with another fall, and now have a subdural hematoma and a positive CT. And it's likely that the second fall was contributed to by some of the post-concussion effects for that individual. So if there is evidence of loss of consciousness or history of change in level of consciousness, I think it does require us to monitor the person for a minimum of several days. Not necessarily by hospitalization, but certainly doing follow-up and ensuring that they're being discharged to a safe environment. Because if someone's had one fall, there's something causing that fall, and so one needs to mitigate those risk factors.
There's a couple of questions that are all tied to this, actually, and I think you may have answered some of it already, Dr. Puxi, but Trudy's asking, is there a list of symptoms that families, advocates, and physicians have or can have to ensure the initial assessment of TBI symptoms? And does this speak to the clinical guidelines that you were just mentioning earlier?
Yes, so they are there, but it's the things you would think of in the sense the individual has abnormal or persistent levels of drowsiness or confusion, evidence of impairment or slurring of speech, persistent headache, visual disturbance, changes in gait or balance. Those will all be cues to that this person probably doesn't have a simple head injury, if there is such a thing.
Thank you. I think that's quite useful. And that also speaks to Julia's question about guidelines to follow up on TBI to watch for early signs of dementia or other cognitive impairment. I think that adequately sort of touches on all of that there. So let me go back up to Carol's question. Pardon me, Carol, for keeping you waiting. Are there stats available that compare rural and urban access to and availability to resources and rehab? I have to regretfully say we can't answer that question here now. It's because it falls under provincial designation as to what services are offered. And so at a federal level, we don't have that information completely compiled, but it would be available from your provincial rep. So I'm not sure which province you're calling from, but that's maybe a resource that you could turn to for that. But it is actually a very valid question about the availability of resources in rehab, and I'll give a slight plug for some of the work that's being done now to encourage aging in place and home care, which would be available at sort of at a federal level through healthcare. It's something for consideration there as well. So just something to bear in mind as we all look at these moving forward. Joanna asks, should recurrent fallers in nursing homes or chronic care hospitals where all types of preventions have been in place use helmets? Joanna, we can't speak to that because we don't have sufficient data to demonstrate that an assistive device like a helmet would necessarily be more effective than other interventions, but certainly an area that might be of great interest for some research at some point because, and I know that there's a lot of great places out there that do a lot of research on those types of assistive devices, so whether hip protectors protect in falling. I think as we start to look at concussion and TBI in older adults, this is another one that needs to start to be looked at. So thank you for your question. Catherine asks, can you please comment on the current practice regarding AF and anticoagulation versus risk of bleeding in frequent fallers? I apologize, Catherine, myself, I can't answer that, but I'm wondering if you might be able to speak to that, Dr. Puxi.
Yes, I can. So if you look at the risk factor of someone with either persistent atrial fibrillation, chronic atrial fibrillation, or someone who's going in and out of atrial fibrillation, the risk of a stroke from the atrial fibrillation is greater than the risk of a fall in terms of head injury, providing, I think the figure is they're not having more than 20 falls a week. So someone's done that calculation. So the message is that providing the individual's not falling multiple times a day or hasn't had a previous head injury, it's still better to anticoagulate someone with atrial fibrillation, although one would want to ensure, particularly if you're using one of the older anticoagulants like warfarin, that one kept their anticoagulation on the lower range of the desirable. So, for example, an INR between perhaps 1.8 and 2.5 rather than higher levels of, say, 2.5 to 3.5. Also, even if there is a concern because of multiple falls and a previous head injury, and the one doesn't want to use oral anticoagulants, there's still a role for perhaps platelet inhibiting agents like aspirin or Plavix in those situations. So we don't have to be nihilistic about their atrial fibrillation.
Thank you. Angela asks, is there any literature regarding the effect of TBI in older adults who are already in the early stages of dementia or mild cognitive impairment? For example, does it change the rate of decline?
Yes, there is evidence. There's been a number of studies, and I think I had them on one of the slides. I'll try and pull it up, which have looked at the impact of TBI both in the situation of no cognitive impairment and also pre-existing cognitive impairment. So the presence of cognitive impairment increases your risk of a serious fall. And a head injury in association with cognitive impairment will result in a likelihood that that cognitive impairment will either be worsened or progress to a dementia in a much shorter timeline than it might have within the absence.
Thank you. I think that's very key to point to, and it certainly is, as the government, I know as we're looking closely at dementia, it's something that we'll want to take into consideration as well. So it's reassuring to know that there's a fair amount of literature available on this. Charlotte asks, does the data consider or disaggregate data on TBI in children and youth caused by participation in sports versus falls, or does it only focus on falls? So Charlotte, I have to say that at this particular presentation and the data was really focused on older adults and falls and didn't get into the breakdown on children and youth. There is a plethora of information available on children and youth and stats, and I would be happy to share some information published by our colleagues in the concussion group at the Public Health Agency of Canada afterwards. If you want to just add your contact information is available, so I can certainly redirect you on that one. Asha asks, given the increasingly limited resources, we are seeing some older adults denied rehab beds because they are going to be in the rehab beds for longer than LOS benchmarks. Those patients, as you mentioned earlier, are then paneled for long-term care, where there is very little targeted care for TBI. Do you have suggestions to help sell why these patients should be considered for rehab versus long-term care? It's an excellent question, Asha, and it's certainly one that speaks to sort of the ageism approach and the short staff, short beds, short funding that happens these days in hospitals. So, Dr. Puxty, can you speak a little bit to that, maybe?
I'm just going to run ahead to the slides. So, key point is that individuals with mild to moderate brain injury will ultimately often get a good outcome similar to that of younger people. It's just that it does take longer. There's probable evidence also that in older adults with TBI, after a year, they're more likely to plateau than younger age groups. So there is a body of evidence to suggest that certainly for mild and probably moderate traumatic brain injury, older adults will benefit from rehab. It's just the rate of improvement may be less than in younger individuals. Now, the problem that creates to hospitals which have moved to performance-based funding is that they may not see the improvement in, say, the FIM that they need to have to justify funding as a rehab bed, and that's an ongoing challenge. So I think there's a recognition that there needs to be what we might term slow stream rehab, where there is a definite benefit to the older adult from the rehab, but it's not going to be necessarily happening within the weeks to short months. It may be months to almost a year to see that maximum benefit, but they do see it. So how to sell it? Well, the literature exists to demonstrate that they will show improvements. And there are criteria that one can use that would help predict at least the mild and moderate who are likely to see some gains. And they would benefit from the same interdisciplinary team approach that would be used in younger individuals with TBI.
And I think that actually nicely rounds up and speaks to some of the other questions that we've had. So from Carol as well, and actually Kadi as well, basically asking what are the interventions done by the agency, what sort of information is available about community care and costs there, and also whether or not there's protocols being developed or should be developed across the healthcare sector for older adults. So these are all very good points, and I think we've spoken to some of the fact that there's the brain injury protocol, that's the guidelines that are available now. The agency produces data which is intended to help inform the development of policies and approaches within the healthcare sector. So exactly what Dr. Puxty was speaking to in terms of using the literature that's available and then summarizing it to explain why a policy should be in place. And I think that we'd be looking to need to update our data on the Seniors Falls report, and we would want to include sections which incorporate TBI, because it is coming out as such a key aspect of consideration. Sorry, I am rushing through because we're down to 12:27, so I'm trying to make sure that everybody gets a chance to talk. Kadi, we have a number of initiatives at the agency in terms of materials being provided free of charge to older adults. It's all on our website, which we'll also provide. Actually, I think Lindsay provided a link to the infographics. Sorry, my brain wasn't working there for a second. Speaking of TBI. So then, Joanna just wanted to ask, what is FIM? And maybe Dr. Puxty, you can answer that in one of the last questions we'll touch on, which is talking about the whether there's better outcomes. Right, let me just read it. Thank you for the talk, Dr. Puxty. You highlighted the QOL in older adults after TBI and the importance of spousal relationships. Do you know if there are better outcomes for males or women when they have spousal support? And knowing that there's a sex-gender difference in individuals with stroke, especially men with stroke that have spousal support have better recovery, wondering if this is the case for TBI in older adults. So if you can speak to that and answer FIM, that would be fantastic.
Okay, so FIM is the functional impairment measure, and it's a measure that's used in rehab typically to measure change over time, and a lot of funding formulas are based on the idea of an improvement in the FIM as an indicator of benefit. The issue about TBI and gender is a fascinating one, which I can't answer quickly, but the general impression is generally, in terms of TBI, there's a slight trend for women to do better than men. But there's evidence that if the male has a supportive spouse, this may enable men to catch up a bit. So there is some gender difference, both in terms of TBI and also if there's a spouse present. Now, part of the issue for the women, of course, is that women often outlive the husband. So we see a lot more older women with TBI who've outlived their spouse as compared to males with TBI, who still have a living and often healthier spouse to support them. So men definitely do benefit, but it may be partially because they actually have a spouse.
Okay, thank you so much. And I realize this brings us to 12:30, and I know this we could talk for like another hour, I'm sure, because there's all sorts of interesting questions. I apologize if I didn't get specifically to some of the comments that came in. I'd like to thank you all for joining us today and being so interactive. It's been a fantastic webinar. I hope you found the presentations useful. I hope you're not leaving, as I am, with more questions and a desire to look into this more. I ask that you please do try to take a moment to complete the post-webinar feedback form you'll receive so that we can ensure we can continue to meet your needs. And I'd like to extend a huge thank you to both Dr. Puxty for his insights and expertise on this matter, and also to the Ontario Neurotrauma Foundation for making this webinar happen today. Thank you so much for joining us, everyone. Have a great afternoon.